Hi there, my name is Dr. Topher Fox, and this video is going to talk a little bit about how we think as endocrinologists, how I think about thyroid nodules. And if you are receiving this, then likely you will be coming to see me regarding a thyroid nodule in the near future. And the goal with this training, if you can call it that, is to ideally answer a lot of basic questions so that when you and I meet, we can focus at a high level and really give you the best experience and make sure that you are getting all of your important questions answered, and of course that we are doing the right thing for evaluation of your thyroid nodule. So I'm going to dive in behind the slides here for a second. And I'll just remind you that before you come see me, make sure you get your two forms in. There's a new patient registration form and a medical history form that are really important and will help to make sure that we have all the information we need and that you are submitting any of the appropriate data that we need, like previous ultrasounds or biopsies or whatnot. So with that as an introduction, let me jump behind the slides here. I'm going to scoot over to this side. And again, we are going to be talking about the evaluation and really treatment and monitoring of thyroid nodules. And so here's what we will cover. What I plan to cover is a little bit about basic thyroid physiology. We're going to talk about how nodules cause problems, or really what types of thyroid problems are there, and then specifically how nodules cause problems, how we evaluate nodules, and then ultimately how nodules are treated or monitored depending on the path that we are taking. And so just so we're on the same page, a little bit about thyroid. We all have a thyroid gland. It's this butterfly-shaped gland. Lives here in the bottom portion of your neck, and it makes hormones. They go by the names T4 and T3. These hormones control your metabolism. Every tissue in your body really responds to these hormones. Now, ultimately, your thyroid gland is under the control of your brain, and specifically a gland called the pituitary, which sits back kind of behind your eyeballs under the front part of your brain. The pituitary gland can sense how much thyroid hormone is in the blood, and then it regulates a hormone called TSH, or thyroid stimulating hormone. It regulates this TSH, trying to keep the thyroid at the right level. So you can think of it kind of like the thermostat and the furnace in your house. Now, for me, when I think about thyroid problems, I like to break them into two discrete categories, two different categories of problems. So we can see functional problems. This is where the gland might be overactive or underactive. And functional problems are where we think about most of the systemic symptoms of thyroid issues. So underactive thyroid can cause things like feeling tired, cold, constipated, muscle pain, dry skin, hair loss. Overactive thyroid might cause heart racing, shakiness, sweating too much, feeling anxious or jittery, hot all the time, unexplained weight loss. These symptoms are, very, like I say, very systemic. They're also what we call nonspecific, meaning these same symptoms occur for lots of different reasons. And so they don't always come from the thyroid, but some simple blood testing usually will help us to determine whether the thyroid is functioning correctly or not. Now, for thyroid nodules, really what we are going to focus on are structural problems, an unusual shape, size, lump, or bump in the thyroid gland. And people can have functional problems, they can have structural problems, they can have both, or if everything's normal, they'll obviously have neither. Now, thyroid nodules, and so a couple representations here of a thyroid gland with one nodule inside it or with multiple nodules inside it. Some basic information: thyroid nodule is really common. They're more common in women than men. They're more common as we get older. So, for example, a woman who reaches age 60, roughly 5% will have a nodule if we try to feel the thyroid gland, and up to 50% will have at least one nodule if we look carefully with a test like the ultrasound. So incredibly common. In men, by the time a man reaches age 60, it may be more like 1 or 2% who have a nodule that we can feel, and upwards of 10 to 20% might have a nodule if we look with the ultrasound. Now, it turns out most commonly having a thyroid nodule is roughly equivalent to having a mole on your skin. So it's something that's not technically normal, but it just sits there. It never causes any problems, and it's benign. And those nodules, I say very common, often need no treatment. Simply, we monitor them, again, very similar to how you might have your skin checked by the dermatologist. Now, thyroid nodules, a small percentage of them can cause problems, and typically they cause problems in one of three ways. So nodules can be cancer. A very small percentage can be cancer. Now, fortunately, thyroid cancer tends to be a slow-growing cancer, and the vast majority of thyroid cancers are treatable and curable. So only about 1% of people who have thyroid cancer ultimately get sick and die because of the thyroid cancer. But anyway, we like to know it if they are cancerous. Sometimes the nodule can grow big enough that it just causes discomfort, sensations of pain or pressure or choking or difficulty swallowing in the neck. And again, these are fairly non-specific symptoms. So usually a thyroid nodule has to be pretty large to interfere with swallowing. And other things like acid reflux or potentially postnasal drip can cause some narrowing in the esophagus that also can cause swallowing issues. And so we'll talk about that if it's relevant for you. And then some nodules will actually make too much thyroid hormone, causing the overactive thyroid or hyperthyroidism that we talked about just a moment ago, with the symptoms of the heart racing, shaky, anxious. And that can be detected on a simple blood test. So when we think about evaluation of nodules, really our goal is to determine which nodules are likely to cause problems. And then we want to intervene or treat those nodules. And for the nodules that aren't causing problems or aren't likely to cause problems, typically we just want to leave those alone and monitor those. So if they're not suspicious for cancer, if they're not large enough to cause symptoms and they're not making too much thyroid hormone, then usually we are simply going to monitor those. The evaluation, our main tools are a couple of things. So we can look at the ultrasound. Thyroid ultrasound is the best way to take pictures of thyroid nodules. So a simple sound wave test. We do that here in the office if you haven't had it done recently. In fact, I like to do my own ultrasound because I can put it together with your clinical picture and I know what I'm looking for. So we can look at the size of the nodule and the pattern of the nodule. I'll explain this in just a minute. And then additionally, this probably should have its own heading here on the slide, but we can look at thyroid blood tests. The main one being this number called TSH, and whether that's abnormal, low or high, or whether it is normal. And ultimately, we will make a decision for nodules about whether to do a test called a fine needle aspiration biopsy, or FNAB, or FNA test to evaluate for cancer. This comes from the American Thyroid Association. It shows a number of nodules. Let me just scoop myself over here. It shows a number of nodules and how they look on ultrasound. And this is just supposed to be descriptive for us. But if we start with the bottom, what we see is a nodule that is a pure fluid nodule. Fluid's going to be black on the ultrasound. So this is just like a simple water balloon. And what we know for thyroid cysts is they're basically always benign. The risk of cancer is less than 1%. And typically we don't need to biopsy these. Then as we move up on the page, as we move north on the page, we see nodules with increasing risk of cancer. So these so-called spongy nodules that have little fluid pockets interspersed with a lace of solid, or a mix of fluid and solid, a mix of fluid and solid. This is what we call a very low suspicion pattern. Less than 3% of those turn out to be cancer. As we come up, nodules that are the same color as the surrounding thyroid or a little bit brighter, or have some fluid with a lump of solid tissue on one side, those we call low suspicion. About 5 to 10% of those turn out to be cancer. Nodules that are darker than the surrounding thyroid, intermediate suspicion, 10 to 20%. Radiologists sometimes will confuse these in their report with these, so often it's worth a look to see which of those is truly present. And then up at the top, we have nodules that have what's called microcalcification or irregular borders or funny lymph nodes associated with them. Those are high suspicion, and more than 70% of those might turn out to be cancerous. Again, what is called out as microcalcification sometimes can be confused with these little white specks that we see in what are called these spongy or spongiform nodules. So we want to take a look carefully. Now, the American Thyroid Association recommends that we think about biopsying these thyroid nodules based on their pattern and size. So we can see no biopsy for those benign ones, and then as we come up, larger than 2 centimeters, 1.5 centimeters, 1 centimeter, 1 centimeter is generally the recommended threshold for biopsy. So again, when we evaluate nodules, we want to determine which ones are likely to cause problems and treat those and leave the rest of those alone. So when you and I meet, we will be looking at all of these things and ultimately making a decision about which, if any, nodules would really be best evaluated by doing this test called the fine needle aspiration biopsy. Now, this test, it's a very simple bedside procedure. We do them in clinic very commonly. They take about 10 minutes to do, and they have about the same risk as having a blood draw. About the same risk as having a blood draw, so a very low-risk procedure. Typically, if you are on blood-thinning medicines like Eliquis or Pradaxa or warfarin, we'll talk about some things that might help us to be best prepared to do the procedure. We can still do it. And for those on warfarin, we like to see that the so-called INR level is at a 3.0 or below before we do that. So if that's useful information for you, store that away. But about the same risk as a blood draw. We use local anesthetic lidocaine in order to numb the skin. So when that goes in, people will feel a little pinch of the needle, and then it burns for about 15 or 20 seconds. Once the skin goes numb, we just take a needle and insert it through that numb spot down into the nodule, and then the needle is going to wiggle back and forth for about 10 seconds to loosen up some cells. To get a good sample, usually we'll do that about 3 or 4 times per nodule. Usually in clinic we're doing 1 or potentially 2 nodules. Most people, when the needles go in, feel a little bit of pressure or discomfort. It's not usually terribly uncomfortable. Most people tolerate it wonderfully well. Some people do get a little pain in the ear. It's just referred from the thyroid. It's how the brain and thyroid are hooked up. It goes away in a few minutes. And again, the procedure is usually well tolerated. After the procedure, there's a risk of pain, as we're talking about now. Bleeding or infection, very uncommon, about the same risk as a blood draw. But after the procedure, if we see a lot of fever, redness, drainage, severe pain or swelling, those would all be things we want to hear about. And then about 5% of the time, we get this thing called a non-diagnostic result. I'll talk about that in a moment. Results usually come back in about 3 or 4 business days after we do the biopsy. And so the results typically can come into 4 main categories. So something called non-diagnostic. This is where the pathologist doesn't see cancer cells, but they don't see enough normal thyroid cells to say that they can say for sure that the nodule is benign. And so depending on our suspicion, we can either just watch, we can wait a little bit and repeat the biopsy, or we can go to surgery, and we would talk through those different scenarios in your case. We can see that the biopsy can return and just show it's a benign nodule, in which case generally we will plan to simply monitor. We can see that it is cancerous or suspicion for cancer, suspicious for malignancy, in which case usually the next step is going to be surgery. And we'll talk through what needs to happen prior to a surgery and which operation would be best served. Most thyroid surgery you can think of as either take out the right half, take out the left half, or take out the whole thing. It's hard for a surgeon just to take out the nodule and leave some remaining thyroid tissue on that side. And then finally, there's a category called indeterminate. Usually this will have some fancy words like atypical cells of undetermined significance or follicular cells of undetermined significance, or they'll use this term suspicious for a neoplasm or suspicious for a follicular neoplasm or a Hürthle cell neoplasm. Basically, these terms mean the pathologists see thyroid cells, but they look a little bit funny, and they can't tell whether they are benign or cancerous with the needle test. And so in this circumstance, we used to send everybody who had this to surgery, but it turns out that there is a style of testing called molecular testing. It goes by names like the Veracyte or the Afirma or the ThyGen-Nex test, that these are tests that can be done to evaluate the nodule further and help refine that risk of cancer. And let me just move on here. So in general, again, we're trying to figure out which nodules need treatment. Options for treatment would include surgery, We can always remove a nodule, even if it's not cancer. If it's large enough to cause symptoms, we can ask a surgeon to take it out, even if it's benign. For nodules that are overactive, we can use something called radioactive iodine, or in the right circumstance, we don't do this very often because it would be a lifelong medication. We can use anti-thyroid medication to slow the thyroid nodule down so it's not making as much thyroid hormone. The radioactive iodine will generally make it smaller. The medication will not. For nodules that are not causing problems, usually simple monitoring, what we call ultrasound surveillance. We might check these once per year. If everything is really stable, we might even go to an every other year assessment. And then I just thought I'd mention something that's becoming more popular as at least an option and more available in the U.S. Right now, it's, as of today, 2022, not available locally here in Boulder County, Colorado. But we have some places in the U.S. where we can send people for something called radio frequency ablation, where they use essentially a little bit of thermal energy through a needle to destroy the thyroid nodule tissue, and this will shrink down benign nodules, not usually to nothing, but it may reduce their size by 50% or more. And if a nodule is just cystic, sometimes we can pull that fluid out, and in some places they'll even put a little bit of alcohol back in to try to keep that from growing back. We'll talk about that if that's relevant in your circumstance. And so really, again, what we've covered here is the thyroid physiology, the types of thyroid problems, and then how we evaluate specifically thyroid nodules and how we treat those nodules. And so I'm going to wrap up for this training, this video, and I just want to, again, remind you, tell you I'm looking forward to meeting you in person in clinic, and just to ask you, do make sure you get your registration form and your medical history form completed before the visit. That just, again, helps us to give you the best experience to focus at the highest level when you come. And I look forward to seeing you then, to meeting you then. Until then, I wish you peace. Take care.